Welcome to the February 2017 podcast from the Journal of Bone and Joint Surgery. This month, our podcast features abstracts of 4 scientific articles published in the February issues of the journal, as well as commentaries by Dr. Brian M. Devitt on the article entitled Total Knee Arthroplasty After Anterior Cruciate Ligament Reconstruction, Not Just a Routine Primary Arthroplasty, and Dr. William G. Hamilton on the article entitled Smoking Increases the Rate of Reoperation for Infection Within 90 Days After Primary Total Joint Arthroplasty. Be sure to check out this month's Current Concepts Review article on Complications of Shoulder Arthroplasty by Dr. Kamal Bolshali and colleagues. In review of the literature from 2006 to 2015 on anatomic total shoulder arthroplasty, TSA, and reverse shoulder arthroplasty, RSA, the authors found that the most common complications after RSA, in order of decreasing frequency, included instability, periprosthetic fracture, infection, component loosening, neural injury, acromial and/or scapular spine fracture, hematoma, deltoid injury, rotator cuff tear, and venous thromboembolism, VTE. The most common complications after anatomic TSA in order of decreasing frequency were component loosening, glenoid wear, instability, rotator cuff tear, periprosthetic fracture, neural injury, infection, hematoma, deltoid injury, and VTE. Glenoid component wear and loosening remains a common cause of failure after anatomic TSA, despite advances in surgical technique and implant design. In addition, diagnostic confirmation of infection after shoulder arthroplasty remains a challenge. Therefore, the surgeon should have a heightened suspicion for infection in the setting of a painful and stiff shoulder after arthroplasty. In this issue, JBJS.org presents a new image quiz, a 2-year-old child with worsening knee pain. Be sure to visit us online to access these features, as well as the full text of the scientific articles you are about to discover in the following podcast. Next, you'll hear the first abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Total Knee Arthroplasty After Anterior Cruciate Ligament Reconstruction, Not Just a Routine Primary Arthroplasty by Dr. Tyler Stephen Waters and Associates. Investigation performed at Colorado Joint Replacement, Porter Adventist Hospital, Denver, Colorado. Despite the success of restoring joint stability and improving early functional outcomes after anterior cruciate ligament ACL reconstruction, the long-term risk of developing symptomatic osteoarthritis requiring total knee arthroplasty is higher than in the uninjured population. The purpose of this study was to compare operative characteristics and early outcomes of patients undergoing total knee arthroplasty after ACL reconstruction with those of a matched cohort of control subjects with primary osteoarthritis and no history of ligament reconstruction. All patients who had undergone total knee arthroplasty from 2005 to 2013 at the author's institution with a history of ACL reconstruction and a minimum 2-year follow-up were identified from a prospective research database. These patients were matched by demographic and surgeon variables to patients who had not undergone prior ACL reconstruction. Outcomes included Knee Society scores, KSS, range of motion, operative variables, complications, and reoperations. A cohort of 122 patients was identified as the ACL study group and was compared with the matched control cohort. The mean age at the time of the surgical procedure was 58 years, and 55% of the patients were male. The mean follow-up was 3.3 years in the ACL group and 3.0 years in the control group. There was no significant difference in the latest KSS outcomes between groups postoperatively. Although preoperative flexion was significantly lower in the ACL group than in the control group, there was no difference between groups postoperatively. 50% of patients in the ACL group required implant removal at the time of total knee arthroplasty. The operative time was significantly longer in the ACL group compared with the control group. There were a total of 11 reoperations in the ACL group, including 4 for periprosthetic infection, whereas there were only 2 reoperations in the control group. The risk of reoperation in the ACL group was more than 5 times higher than in the control group. Conclusions. The results of this retrospective matched cohort study suggest that prior ACL reconstruction results in longer operative time and increased risk of early reoperation after total knee arthroplasty. Next, you'll hear a commentary by Dr. Brian M. Devitt on the article entitled Total Knee Arthroplasty After Anterior Cruciate Ligament Reconstruction, Not Just a Routine Primary Arthroplasty.
This is Dr. Brian Meldon Devitt providing commentary for the February 2017 JBJS podcast. I will be providing commentary on the article entitled Total Knee Arthroplasty After Anterior Cruciate Ligament Reconstruction, Not Just Another Routine Primary Arthroplasty. The title of my commentary is Forewarned is Forearmed. The very nature of sport is that it can occasion harm and involves various degrees of risk, which is perhaps one of the reasons that it is so compelling for both participants and spectators. However, there is often an adversarial relationship between sporting performance and patient welfare. As a doctor, one of the primary tenets governing clinical practice is primum non nocere, first do no harm. This raises challenging ethical dilemmas in the context of sports medicine, in which orthopedic surgeons are frequently called upon to treat patients injured playing sport with the explicit goal of returning these patients to the same sport and thus back into harm's way. Players participate in sport of their own volition, and the principal motivation of the orthopedic surgeon is one of beneficence. The primary aim is to do good for the patient by treating any injuries that may occur and to prevent any further harm. In the context of anterior cruciate ligament injuries, patients need to be made aware of not just the inherent risks they face in the short term, but also the long-term sequelae such as osteoarthritis. Equally, surgeons also need to be aware of the potential risks if total knee arthroplasty is required in the future. Although an ACL reconstruction may facilitate patients returning to sport, it has not been shown to prevent them from developing osteoarthritis later in life. Therefore, as the rate of ACL reconstruction increases exponentially, so too will the requirements for total knee arthroplasty for these patients in due course. In this article, Waters et al. Have demonstrated that these knee arthroplasties are not just routine primary arthroplasty and carry some hidden challenges and potential complications. The authors present the results of a cohort of 122 patients undergoing total knee arthroplasty after ACL reconstruction, comparing them with those of a control group of patients undergoing routine primary knee arthroplasty for osteoarthritis. Interestingly, although both groups demonstrated equivalent functional outcome at a follow-up of 3 years, there was a significantly greater risk of reoperation in the ACL group. More concerningly was the markedly increased rate of infection postoperatively, which was 3.3%. These results beg the question whether we should be adopting a two-stage policy for these cases to remove metal components, given this unacceptably high rate of infection. Although the authors do not provide a definitive answer to this question, they do offer some helpful technical tips for dealing with retained implants at the time of primary knee arthroplasty. They also refer to the fact that exposure is more difficult and time-consuming in the group undergoing total knee arthroplasty after ACL reconstruction and provide some suggestions on how to deal with it. In general, if harm has already been done, it is probably best not to add to it. Surprises are not welcome in the operating room, but frequently appear at the most inopportune time. In my opinion, this article is extremely useful and details clearly the potential challenges that orthopedic surgeons may face in dealing with an increasingly more common group of patients requiring total knee arthroplasty. An awareness of these issues with preoperative planning and appropriate patient counseling is extremely helpful. After all, in surgery, as in life, forewarned is forearmed.
Next, you'll hear the second abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Patient and Radiographic Factors Help to Predict Metal-on-Metal Hip Resurfacings with Evidence of a Pseudotumor by Dr. Gulraj S. Mathuru and Associates. Investigation performed at the Nuffield Department of Orthopedics, Rheumatology and Musculoskeletal Sciences, Nuffield Orthopedic Center, University of Oxford, Oxford, United Kingdom. The role of radiographs in the follow-up of patients with metal-on-metal hip resurfacing implants is unclear. The authors investigated whether a combination of patient and radiographic factors predicted metal-on-metal hip resurfacings with evidence of a pseudotumor. The authors performed a retrospective single-center case control study of 384 metal-on-metal hip resurfacings with the pseudotumor group of 130 hips. All had evidence of a symptomatic pseudotumor on cross-sectional imaging, with the diagnosis confirmed at revision. The non-pseudotumor group of 254 hips, a subgroup of these hips was previously reported on, all had normal findings on cross-sectional imaging. Radiographs taken immediately prior to revision were assessed in the pseudotumor group and were compared with radiographs taken at the time of normal cross-sectional imaging in the non-pseudotumor group. 2 blinded independent observers analyzed the radiographs for signs of failure, with excellent inter-observer agreement. Logistic regression remodeling identified the patient and radiographic predictors of revision for pseudotumor. Hips with a pseudotumor more commonly had abnormal findings on radiographs compared to hips without a pseudotumor. Patient and radiographic factors predictive of revision for pseudotumor in the multivariable model were female sex, high inclination, acetabular osteolysis, femoral osteolysis, and acetabular loosening. Factors predictive of not having a pseudotumor were anteversion of greater than or equal to 5 degrees and heterotopic ossification. The final multivariable model was well calibrated with good discriminatory ability. Conclusions. A combination of patient and radiographic factors provided useful information for distinguishing between metal-on-metal hip resurfacings with and without evidence of a pseudotumor. Surgeons may wish to consider these specific patient and radiographic factors before proceeding with cross-sectional imaging. Radiographs are important when assessing patients with metal-on-metal hip resurfacing implants and should be included in all follow-up protocols. Next, you'll hear the third abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Smoking Increases the Rate of Reoperation for Infection Within 90 Days After Primary Total Joint Arthroplasty by Dr. Eric H. Tisler and Associates. Investigation performed at the Rothman Institute at Thomas Jefferson University, Philadelphia, Pennsylvania. The relationship between smoking and complications after total joint arthroplasty is unclear. Prior studies have been limited by relatively small sample sizes or investigation of select cohorts. The purpose of this study was to investigate the association between smoking and readmission and/or reoperation within 90 days of total joint arthroplasty in a large, non-select cohort of patients. Using their institutional database, the authors retrospectively identified patients who underwent primary total joint arthroplasty between 2000 and 2014. Patients were stratified into one of 3 groups: current smokers, former smokers, and non-smokers. The association between smoking status and subsequent readmission and/or reoperation within 90 days was investigated using multivariate regression analysis. The authors retrospectively identified 15,264 patients, 6,749 male and 8,515 female, who underwent 17,394 total joint arthroplasties during the study period. Of these patients, 1,371 were current smokers, 5,195 were former smokers, and 8,698 were non-smokers. Former smokers reported a median of 22.2 years of abstinence prior to the surgical procedure. Current smokers were significantly younger at a mean age and standard deviation of 57.7 plus or minus 10.3 years than non-smokers at 63.2 plus or minus 11.8 years. Current smokers were significantly more likely than non-smokers to undergo reoperation for infection, and former smokers were at no increased risk. Packs per decade were independently associated with an increased risk of 90-day non-operative readmission, regardless of smoking status. Lastly, neither smoking status nor packs per decade were associated with aseptic or total reoperations. Conclusions. This study, after controlling for confounding factors, demonstrated not only that current smokers have a significantly increased risk of reoperation for infection within 90 days of a surgical procedure compared with non-smokers, but also that the amount that one has smoked, regardless of current smoking status, significantly contributed to increased risk of non-operative readmission. Next, you'll hear a commentary by Dr. William G. Hamilton on the article entitled Smoking Increases the Rate of Reoperation for Infection Within 90 Days After Primary Total Joint Arthroplasty.
This is Dr. William G. Hamilton providing commentary for the February 2017 JBJS podcast. I will be providing commentary on the article entitled Smoking Increases the Rate of Reoperation for Infection Within 90 Days After Primary Total Joint Arthroplasty. The title of my commentary is, No Smoking Allowed. Is the operating room the next place that smoking patients undergoing total joint arthroplasty will be banned? In the current era of cost containment, bundled payments, and maximizing value to our patients and hospitals, total joint surgeons are on the hunt for strategies to reduce complications following hip and knee total joint arthroplasty. There have been studies that have identified factors that increase the total joint arthroplasty complication rate, including age, obesity, medical conditions, and socioeconomic status. Smoking has been previously identified as a substantial health risk, so the natural question would be, how does smoking influence the outcomes of total joint arthroplasty? In this study, Tischler et al. Attempt to answer that question. Using an institutional database, 15,264 patients who underwent 17,394 total joint arthroplasties were retrospectively studied, and the authors analyzed the association between their status as current smokers, former smokers, or non-smokers, and post-op complications, including infection, aseptic reoperations, and readmissions. Smokers were nearly twice as likely to undergo reoperation for infection, one of the most costly complications that joint replacement surgeons incur. This study is subject to the weaknesses of any institutional database study. My main concern in calculating complications using an institutional database is the potential for patients lost to follow-up, especially in a city such as Philadelphia, where there are many hospitals in which patients could have their complications treated. The massive size of the patient cohort, along with the expected equal distribution of loss to follow-up between groups, should overcome that concern. Another concern is the possibility that the differences found between groups may not have been due solely to the smoking status, but rather to a condition or behavior that is associated with smoking. The authors explain how they address that concern by performing a series of regression analyses to isolate the effects of smoking. The authors and their institution should be commended for not only prospectively collecting such a massive quantity of data, but then assembling the data in a well-performed study. Prior studies have examined the relationship between smoking and orthopedic procedures. Cancien et al. Documented an increased rate of infection and venous thromboembolism following anterior cruciate ligament reconstruction. Dutchman et al. Queried the National Surgical Quality Improvement Program database of nearly 80,000 total joint arthroplasties and reported that both former and current smokers had increased total complication risk, and current smokers had increased rates of wound complications. Surprisingly, Tischler et al. Did not find an association with increased wound complications. There is a difference between modifiable and non-modifiable risk factors in total joint arthroplasty. Mayaz et al. Discussed the effect of modifiable risk factors such as tobacco use, obesity, operative time, and Staph aureus colonization, each of which increased the risk of infection after total hip arthroplasty. The question remains to what extent we should attempt to reduce these factors prior to the surgical procedure in our patients undergoing total joint arthroplasty. The questions that we need to pose include, is a patient's access to a total joint replacement a right or a privilege? Do we have the resources to perform these procedures in higher risk patients, especially when their own modifiable behaviors are contributing to these risks? Obviously, we would not intentionally limit access to care on the basis of socioeconomic status, even with suboptimal outcomes. So, should we limit the access for smokers or for obese patients? The answers to these questions can be emotionally charged and complex, and will require thought and discussion. I think it's safe to suggest that as physicians, we should work cooperatively with our patients to enhance outcomes by attempting to reduce these modifiable risk factors. We can educate patients and can suggest smoking cessation programs and weight loss regimens that may not only improve the risk profile during the surgical episode, but also improve the patient's overall health. Further research will need to be performed to determine if these efforts are warranted and effective.
Next, you'll hear the last abstract of 4 that are being presented in this podcast. This abstract is from the article entitled 12-Year Outcomes of an Oxinium Total Knee Replacement Compared with the Same Cobalt-Chromium Design, an analysis of 17,577 prostheses from the Australian Orthopaedic Association National Joint Replacement Registry by Dr. Christopher J. Vertullo and Associates. Investigation performed at the Australian Orthopaedic Association National Joint Replacement Registry. Oxidized zirconium, Oxinium, was introduced as an alternative bearing surface to cobalt-chromium in an attempt to reduce polyethylene wear and decrease aseptic mechanical failure of total knee replacements. While non-comparative reports have been described as promising, the authors were aware of no short or long-term clinical studies showing the superiority of Oxinium on polyethylene as a bearing surface. Using data from a comprehensive national joint replacement registry, the authors compared the long-term outcomes after Cruciate retaining total knee arthroplasty, TKA, with an Oxinium femoral component, and those with the same prosthetic design but with a cobalt-chromium femoral component. The cohorts consisted of 17,577 cemented Genesis II Cruciate retaining total knee replacements using non-cross-linked polyethylene, which included 11,608 with cobalt-chromium femoral components and 5,969 with Oxinium femoral components. The cumulative percent revision and hazard ratio for revision risk were estimated for the cemented Genesis II Oxinium and cobalt-chromium Cruciate retaining TKAs performed in Australia from September 1, 1999 to December 31, 2013. In addition, the revision diagnoses and the effects of age and patellar resurfacing were examined. No difference in the hazard ratio for revision risk was found between the Oxinium and cobalt-chromium cohorts for any age category for all causes of revision, loosening, or lysis, or aseptic causes, except for loosening or lysis in the group of patients who are 75 years old or greater. In these patients, TKA with Oxinium femoral components had a higher rate of revision. Younger patients preferentially received Oxinium femoral components. The revision risk was not affected by patellar resurfacing or non-resurfacing. At 12 years, the cumulative percent revision was 4.8% for the cobalt-chromium Genesis II prosthesis, compared with 7.7% for the Oxinium Genesis II prosthesis. Conclusions. In this cohort study involving the same prosthetic design, Oxinium femoral components did not reduce revision rates for all causes, loosening or lysis, or when infection as a cause of revision was removed, compared with the same cobalt-chromium femoral component across all age groups, including patients who are less than 55 years old. The cumulative percent revision was greater for the Oxinium components than for the cobalt-chromium components. Thank you for listening to this JBJS podcast. Please visit www.jbjs.org for commentary and perspective on many of the articles presented in this podcast, and for more content of interest.